When a patient spikes a fever shortly after surgery, the instinct to immediately order cultures and start antibiotics is often incorrect. Postoperative fever triage is strictly dictated by the specific number of hours that have passed since the operation. This timeline outlines the chronological causes of postoperative fever. In the immediate 0 to 6 hour window, the differential is narrow: tissue trauma, reactions to blood products, or the onset of malignant hyperthermia. Malignant hyperthermia presents with masseter muscle rigidity and sinus tachycardia. The most reliable indicator during the operation is hypercapnia, a sudden, unexplained rise in end-tidal carbon dioxide. A common examination trap is attempting to treat this condition with standard antipyretics. Because the mechanism involves a massive release of intracellular calcium leading to muscle breakdown, the diagnosis is confirmed by checking for massively elevated creatine kinase levels. Immediate postoperative fevers generally represent physiological or iatrogenic crises, not bacterial infections. Medical stabilization and specific antidotes are the priority over starting empiric antibiotic therapy. Moving past the first day into the acute and subacute windows, the diagnostic focus shifts toward nosocomial infections and anatomical failures. A persistent misconception in postoperative care is that atelectasis, the collapse of alveoli, directly causes fever in this early period. In reality, the collapse is a consequence of poor ventilation. When pain control is inadequate, patients limit their breathing depth to avoid discomfort, a process called respiratory splinting, which prevents full lung expansion. The actual drivers of fever in this time frame include hospital-acquired pneumonias, catheter-associated urinary tract infections, and early-onset surgical site infections. Once a fever crosses the 24-hour mark, management requires a targeted investigation into hospital-acquired pathogens or structural failures at the operative site, rather than the trauma of the surgery itself. Evaluating structural failures requires an anatomical descent. Patients with systemic risk factors, such as obesity, uncontrolled diabetes, and a history of smoking, face the highest risk for wound complications. This table outlines necrotizing fasciitis manifestations. The primary sign of this aggressive infection is severe pain, out of proportion to examination findings. Finding subcutaneous gas, crepitus, or dishwater drainage mandates immediate surgical debridement. Do not wait for confirmatory imaging. If the wound separates without signs of infection, the critical boundary is the rectus fascia. You must determine if the separation is superficial or if the fascia layer is broken. A superficial separation involves only the skin and subcutaneous tissue. With the rectus fascia intact, the presentation usually involves scant serosanguineous fluid and is managed with local dressing changes. A deep fascial dehiscence, or evisceration, exposes the intra-abdominal organs. This carries a high risk of bowel strangulation and requires covering the tissue with saline-soaked gauze and an immediate return to the operating room. The integrity of the rectus fascia dictates the management path. If the fascia is closed, the wound is a medical problem. If it is broken, the patient belongs in the operating room. The concept of boundary failure extends to the chest wall following a coronary bypass. Sternal dehiscence, marked by chest wall instability or a palpable rocking and clicking with movement, requires urgent surgical repair. If that mechanical instability progresses to acute mediastinitis, the patient will develop fever, leukocytosis, and purulent drainage, necessitating both surgical debridement and prolonged intravenous antibiotics. This diagram of a Roux-en-Y gastric bypass illustrates another critical junction, the gastrojejunal anastomosis. A leak at this junction allows gastric contents and oral bacteria to track into the sterile abdominal cavity, leading to rapid onset sepsis. The most sensitive early predictor of an anastomotic leak is a sustained heart rate over 120 beats per minute. This infectious leak must be distinguished from dumping syndrome. Dumping syndrome is a hypertonic fluid shift managed by diet and replacing simple sugars with complex carbohydrates, rather than surgical revision. In these complex recoveries, recognizing early mechanical instability, like a clicking sternum or leaking junction, offers a critical window to intervene before systemic sepsis takes hold. Inside the bowel lumen, delayed recovery presents as either a paralytic ileus or a mechanical small bowel obstruction. This X-ray reveals a postoperative ileus, showing simultaneous dilation of both small and large bowel loops. The lack of a transition point confirms a diffuse paralysis, often driven by metabolic derangements or opiates. typically presenting with absent bowel sounds. By contrast, this radiograph demonstrates a mechanical small bowel obstruction. Proximal small bowel dilation with air fluid levels is visible, while the distal large bowel is decompressed. This abrupt cutoff is the transition point, confirming a physical blockage. While an uncomplicated small bowel obstruction is managed with nasogastric decompression, clinical signs like fever, tachycardia, or peritonitis suggest bowel strangulation and necessitate emergency surgery. Locating a definitive radiological transition point is the deciding factor between initiating medical bowel rest and proceeding to an emergent laparotomy. Some conditions mimic surgical emergencies but require non-operative management. A rectus sheath hematoma is caused by a rupture of the inferior epigastric artery, often triggered by severe coughing. Using the Fothergill sign, when flexing, a rectus sheath hematoma remains stationary. Since bleeding is contained, manage with serial blood counts and anticoagulation reversal. Similarly, pediatric duodenal hematomas present 24 to 36 hours after blunt abdominal trauma with bilious vomiting. They are managed with nasogastric decompression and parenteral nutrition. This contained hematoma must be distinguished from a duodenal perforation, which would show retroperitoneal free air on a CT scan and require immediate surgical repair. Identifying distinct signs like the Fothergill sign or tracking the specific trauma timeline prevents unnecessary and potentially dangerous operative explorations. Finally, we evaluate localized peripheral complications, such as postoperative suppurative parotitis. Strict fasting and the use of anticholinergic medications can decrease salivary flow. This stasis allows oral bacteria to mount a retrograde infection up the parotid duct. Treatment focuses on intravenous hydration and glandular massage, reserving surgical incision and drainage for cases that develop into a true abscess. Another localized entity is pilonidal disease, which presents in the intragluteal cleft as a painful, fluctuant mass with purulent discharge. Because the infected hair follicle has already formed an abscess cavity, the immediate next step is surgical incision and drainage. From a bariatric anastomosis to a salivary duct, postoperative management relies on protecting anatomical boundaries and ensuring the unobstructed flow of physiological fluids.